So if a surgeon wants to cosmetically enhance a woman's G-spot, right, they don't actually inject filler into the vaginal wall. They inject it through the urethra.
Right, which is, I mean, it's wild, but because when it comes to the female pelvis, absolutely nothing is where you think it is.
Yeah, and everything is connected. Welcome to today's deep dive, by the way.
Thanks. Yeah, it completely subverts our basic assumptions about human anatomy. You're dealing with this incredibly dense, weight-bearing hammock, right? It's full of muscles, nerves, and organs all packed into this tiny space.
And because it's completely hidden from view, the structural reality of it is often just replaced by guesswork and, marketing.
Exactly. Which makes fixing it, or even just understanding it, a massive challenge.
So that is exactly what we are doing today. We are taking a journey into the complex and honestly wildly misunderstood landscape of female pelvic health. And we've got a really fascinating stack of sources for this deep dive.
We really do. It's a vast spectrum of medical literature.
Yeah, we're pulling from global obstetric manuals on obstructed labor, urogynecology, surgical protocols, modern women's health clinic FAQs, and even the latest ultrasound imaging guidelines.
We are spanning everything from these life-saving, bare-bones interventions in rural clinics all the way to the, well, highly lucrative world of modern cosmetic gynecology.
And our mission today is to separate anatomical fact from internet fiction. We're going to explore how medical professionals actually measure, protect, and repair the pelvic floor.
Because it's so important.
It is. Whether you are navigating healthcare for yourself or supporting a partner, or you're just insanely curious about medical science, the pelvic floor is a structural marvel. I mean, it affects half the population, but it's rarely discussed with this level of clinical clarity.
Think about a suspension bridge. It's an engineering marvel, right? They have these steel cables, which they act like the ligaments in the pelvis. And you have the deck of the bridge, which represents the pelvic floor muscles.
Okay, a suspension bridge. I can picture that.
Right. And under a dynamic load, that bridge flexes, but the tension is perfectly calibrated so it just doesn't break.
But the difference is, if a real suspension bridge starts to fail, an engineer can just look at it in the light of day. They can see the rusted cable or, measure the stress point. But when you move from steel and concrete to human anatomy, the lights go out.
They do. That hidden nature creates a vacuum of understanding. And into that vacuum rushes, well, a lot of misinformation. So looking at the actual clinical mechanics of how this bridge operates and how doctors repair it is incredibly empowering.
So before we can even talk about repairing that bridge, we have to look at the most intense physical event it can possibly undergo, which is childbirth. Talk about a dynamic load.
Oh, absolutely.
And looking at our sources, there's this stark, almost jarring contrast in how this event is managed globally. The text described two just completely different worlds of obstetrics.
The disparity is profound. And it really just comes down to resources. In advantaged, industrialized nations, cesarean sections have become so incredibly safe that they've changed the entire pattern of obstetrics.
Right. In some places, they're used electively for up to 40% of women.
Yes, surgeons use them to anticipate difficulty, controlling the environment before a crisis ever even occurs.
But then the manual pivots to low-resource settings, and the reality is intensely different. Out there, prolonged or obstructed labor isn't just a tough delivery. I mean, it's a leading cause of maternal mortality, devastating fistulas, and uterine rupture.
It's brutal.
I was reading the section on uterine rupture, and it's terrifying. A woman might labor for days in a distant village, the baby cannot pass, and the sheer mechanical force of the uterus contracting against a physical blockade, it eventually just tears the organ open.
And even if she survives, right, and she gets a C-section in a rural hospital, the scar left on her uterus becomes a massive risk for her next pregnancy.
Oh, wow. Because it's a structural weak point now.
Exactly. Especially in regions where cultural or economic pressures dictate she might have, 6 or 7 children to ensure a few survive to adulthood. A C-section doesn't fix the underlying mechanical issue, which is often cephalopelvic disproportion.
Wait, cephalopelvic disproportion, meaning the baby's head is literally just too big to fit through the mother's skeletal pelvis.
That is the core of it, yeah. The structural geometry simply does not align. So if you are a peripheral health worker in a rural clinic and a surgical team or a blood bank isn't readily available, you need a way to predict that geometric failure.
Right, before the tissues literally start dying from pressure.
Exactly.
Okay, let's unpack this because this is where one of the most brilliant medical tools I've ever seen comes into play. It's called the partograph. And looking at it, it's essentially a GPS navigation system for labor.
It really is. What's fascinating here is it's just a simple single-page visual graph,
Yeah.
and it tracks the precise progress of labor over time. It fundamentally changes how medicine is practiced in these settings.
It's so clever in its simplicity. On the vertical axis, you're plotting two specific things. First, the dilation of the cervix in centimeters. Second, the descent of the fetal head.
Right, the
And
descent.
the manual measures that descent in fifths above the pelvic brim, which is basically how much of the baby's head the doctor can still feel above the pelvic bone. Then, on the horizontal axis, you have time in hours.
But the real genius of the partograph lies in these two diagonal lines printed right across the center of the graph. You have the alert line and the action line.
Okay.
Simply plotting a woman's progress against these two lines prevents 70% of maternal deaths from neglected obstructed labor in some regions.
70%.
Yeah.
That is wild. So if the line plotting the mother's progress hits that first diagonal, the alert line, the GPS is basically saying, traffic is slowing down, pay attention.
Yes.
But if her progress crosses over 4 hours later and hits the second diagonal, the action line, the alarm bells go off, the GPS says you must reroute and intervene immediately.
Right. And that specific 4-hour window between the alert and action lines, that's a built-in safety buffer. It gives health workers the physical time they need to load a patient into a vehicle and transfer her to a central hospital.
Before the uterus ruptures or the vaginal tissues become necrotic from the pressure of the baby's head.
Exactly. It takes the guesswork out of it entirely.
But this raised a massive question for me while I was reading. What if the GPS says you've crossed the action line, the labor is fully obstructed, but you're in a rural clinic and the transfer vehicle is broken down?
Oh, yeah.
You don't have a surgical team, you can't just do a C-section. What then?
Well, the texts detail some incredibly intense alternatives that rely entirely on mechanical problem solving. If the baby's head is low enough in the birth canal, the doctor will use vacuum extraction to provide a pulling force.
Right.
But if the baby is stuck higher up because of that true cephalopelvic disproportion, the doctor might perform a symphysiotomy.
I had to read that section twice. That is where they physically widen the mother's pelvis, right?
They do, yeah. The human pelvis isn't one solid ring of bone. At the very front, where the two halves meet, there is a joint made of cartilage called the pubic symphysis.
Okay.
In a symphysiotomy, the doctor uses a scalpel to divide that cartilage under local anesthesia.
So they're snipping the connective tissue, holding the front of the pelvis together. How does that even help?
By severing that cartilage, the two halves of the pelvis can actually swing open on their back hinges, the sacroiliac joints, just a few millimeters, sort of like a pair of double doors.
Oh, wow.
Yeah, and it instantly creates the necessary space for the baby's head to pass.
It just sounds so extreme to a modern listener.
It does, I know. But consider the context. The side effects of a single symphysiotomy, which usually involve a few weeks of pelvic rest and walking with a cane while the cartilage heals, are vastly less dangerous than the side effects of repeated C-sections in a setting without a blood bank or sterile operating theaters.
That makes total sense.
It's a mechanical solution to a mechanical problem that saves 2 lives in a matter of minutes.
It really puts the realities of global healthcare into perspective. So we have this acute, incredible trauma of childbirth, testing the limits of our suspension bridge. But what happens when the load isn't temporary? What happens decades after the baby is delivered when we look at the chronic aftermath?
That brings us to structural failure over time. Aging, gravity, and the sheer force of childbirth can lead to a loss of connective tissue support. In the medical field, this is called pelvic organ prolapse, or POP, along with general tissue laxity.
And this brings us to a massive point of internet misinformation. If you are listening to this and you've ever fallen down a WebMD rabbit hole late at night or felt anxiety because of a TikTok video talking about the 2-finger test for vaginal looseness, you need to hear this next part.
Yes, absolutely.
Because according to the clinic FAQ source we reviewed, this test is complete fiction.
The source is remarkably strict about debunking this. The 2-finger test is not a validated medical assessment in any capacity. It is a crude, unstandardized, and entirely subjective self-judgment.
Why is it so useless structurally? Like from an anatomical standpoint?
Because it fails to account for basically every variable. I mean, finger size varies wildly. A woman's level of arousal or pelvic floor tension varies. Expectations vary. Placing fingers inside the vagina tells you absolutely nothing about the actual integrity of the ligaments holding up the bladder.
Or the coordination of the pelvic floor muscles, I imagine.
Exactly. None of that is captured.
All it seems to do is create unnecessary anxiety and body shame. It reduces a highly complex structural system to a meaningless idea of tightness,
Right.
which means women might be ignoring actual medical symptoms, like a prolapsing organ, because they passed some arbitrary home finger test. Or, conversely, they feel broken when they're perfectly healthy.
This raises an important question, though. If subjective home tests are a myth, how do doctors objectively measure when the pelvic bridge is sagging? Because you absolutely cannot engineer a surgical fix without a quantified map of the failure.
So what are the actual structural engineering tools they use?
The gold standard in a clinical setting is the POPQ system, the pelvic organ prolapse quantification system. It's a highly specific topographical map of the vagina. Doctors don't guess. They measure specific compartments using a physical ruler.
And the hymen acts like the 0 point on an XY axis in this mapping system, right?
That is the anchor point. Measurements taken inside the body above the hymen are recorded as negative numbers in centimeters.
Okay.
Measurements of tissue bulging outside the hymenal ring are positive numbers. They measure the anterior wall to check for a cystocele, which is when the connective tissue fails and the bladder bulges down into the vaginal space. And they measure the posterior wall for a rectocele, where the rectum bulges forward.
So it is purely objective. And for the subjective feeling of looseness, they don't use fingers at all. They use the VLQ, the Vaginal Laxity Questionnaire, which is a validated 7-point patient-reported scale to track symptoms systematically.
Right, they rely on standardized data, but
Yeah.
the most fascinating diagnostic tool in our sources was the transperineal ultrasound, or TPUS.
Yeah, the integration of dynamic imaging is changing everything. We're talking specifically about diagnosing stress urinary incontinence here.
Yes.
Right? Which is when you leak urine when you cough, jump, or sneeze. I always assumed doctors just took a patient's word for it, but they don't just guess. They use ultrasound to measure the literal angle of the urethra.
They do. They capture an image of the urethral angle while the patient is completely at rest. Then, they ask the patient to perform a Valsalva maneuver.
Which is bearing down. It's the exact same internal abdominal pressure you create when you're trying to lift a heavy-moving box off the floor.
Exactly. And the math they apply to that ultrasound image is incredibly precise. If that urethral angle changes by more than 16 degrees between resting and bearing down, it objectively proves the patient has stress urinary incontinence.
Wow, 16 degrees.
Yes, it physically proves that the anatomical hammock supporting the urethra has lost its structural tension.
Here's where it gets really interesting. Once you've mapped that failure, whether it's with a POPQ ruler or an ultrasound proving a 16-degree angle shift, how do you actually go in and engineer the fix?
Well, to fix stress urinary incontinence, surgeons often install slings. The sources detail procedures like the tension-free vaginal tape or a birch colpost suspension, and the anatomy they are navigating to place these slings is just dangerously delicate.
Yeah.
You have the urethra, the bladder, major nerves, and a rich, thin-walled venous blood plexus, all packed right against each other.
I was reading the surgical protocol for placing one of these slings,
Yeah.
and the precision required is mind-blowing. The surgeon uses a specific Foley catheter, and not just any tube, but one where they inflate a tiny balloon with exactly 10 cubic centimeters of fluid.
Yep.
They pull that balloon back until it gets stuck, which physically identifies the urethra-vesical junction.
The exact spot where the bladder empties into the urethra. You absolutely cannot guess where that junction is when you are about to pass sharp surgical instruments blindly through the surrounding tissue. You need that balloon acting as a physical bumper you can feel from the inside.
And then, to create a safe path for the surgical trocar, which is the sharp metal instrument that actually pulls the mesh sling through the body, they use a technique called hydrodissection.
Yes.
The text describes them injecting 10 cc's of fluid into the vaginal skin right below the urethra, making it balloon out like a white marble.
That fluid injection is a brilliant mechanical trick. It physically separates the layers of tissue. It pushes the vaginal mucosa away from the urethra, creating a temporary water-filled zone of safety.
So when they push the sharp trocar through, they're sliding through the water cushion, and they don't puncture the bladder.
Exactly.
But wait, they guide this trocar blindly, aiming directly toward the patient's ipsilateral shoulder, meaning the shoulder on the same side of the body. Why that specific angle?
It's pure structural geometry. By angling the instrument precisely toward the ipsilateral shoulder, the trocar perfectly bypasses the critical blood vessels and the bowel, sliding safely behind the pubic bone to anchor the sling. It's really a masterclass in spatial awareness.
And that same level of blind anatomical precision applies to how they manage severe pelvic pain, right? I'm looking at the notes on the pudendal nerve block.
Right.
The pudendal nerve is the main sensory nerve for the pelvic floor, and if it's inflamed, the pain is just agonizing. The text contrasted two ways to numb it. One is using ultrasound guidance, which makes total sense, but the other is the finger-guided trans-vaginal technique.
This highlights the incredible tactile skill historically required in pelvic medicine. The doctor places their index and middle fingers inside the vagina to physically palpate a tiny deep bone called the ischial spine.
Wait, they're finding a tiny bone landmark deep inside the pelvis in the dark just by touch.
They are, and once they feel that specific bone, they guide a needle exactly 10 millimeters posterior and 10 millimeters medial to that spine. That exact coordinate is where the pudendal nerve runs. It is performed entirely blindly, but it's anatomically exact.
It's like finding a single specific structural cable on our suspension bridge in the pitch black just by feeling the vibrations in the concrete. That is incredible.
It is the absolute pinnacle of medical necessity meeting anatomical expertise. We are talking about objective structural fixes for objective structural failures, but what happens when that clinical objectivity gets hijacked by internet anxiety and cosmetic marketing? That brings us to our final topic.
Oh yes, we are leaving the world of life-saving labor charts and precision surgical geometry and entering the highly lucrative, very wild west of aesthetic and cosmetic gynecology.
It is a booming industry, driven largely by aggressive marketing and the very insecurities we discussed earlier regarding subjective tests of tightness.
So let's talk about lasers. Specifically, the Mona Lisa Touch, which is a fractional CO2 laser. If you look online, this is marketed heavily for vaginal rejuvenation and tightening. But looking at the clinical evidence in our sources, the reality is a completely different story.
The clinical evidence is decidedly mixed,
Okay.
and the mechanism of action is frequently misrepresented to patients. The laser creates microscopic thermal zones, which is really just a polite way of saying controlled heat damage in the mucosal lining of the vagina to stimulate tissue remodeling and collagen production.
Which, okay, might legitimately help with surface issues like postmenopausal dryness or superficial tissue health. But wait, if a patient has an actual structural weakness in their pelvic floor, like their connective tissue is torn and their bladder is prolapsing downward, isn't using a surface laser to tighten the vagina basically like trying to fix a sagging roof by repainting the ceiling?
That is exactly what it is. A laser applied to the superficial mucosa cannot repair torn ligaments. It cannot rebuild the structural hammock of the pelvic floor. It absolutely cannot fix a prolapse. This is why the clinic source is so adamant that a physical, structural assessment must come before any cosmetic laser treatment. You cannot laser away a mechanical failure.
And if the laser marketing is misleading, the anatomy of G-spot augmentation is just fully counterintuitive. Let's go back to that fact we mentioned at the very beginning of the show.
Oh, right. This is where anatomical reality completely shatters public expectation.
Okay, so G-spot augmentation uses a bulking filler. The source mentions a synthetic one called macroplastique to make the G-spot more prominent and increase friction. But according to the plastic surgery textbook in our stack, they do not inject this filler into the vaginal wall.
No, they do not. And the reason comes down to embryology and microanatomy. The erectile tissues that make up what we culturally call the G-spot sit very superficially, just below the vaginal mucosa.
Hold on. If the tissues are right there under the vaginal skin, why don't they just inject the vagina?
Because if you inject the vaginal wall directly, you risk burying those sensitive tissues under the filler, or missing the structural plane entirely. The bulk of those sensitive erectile tissues actually lie closer to the urethra than the vaginal cavity.
Okay.
So to push them forward, the surgeon injects the filler transurethral.
Wait, they go through the urethra, the tube you pee out of.
Yes, they pass a needle just under the musculature of the urinary tract. By placing the filler bolus there, it acts as a wedge, physically pushing the G-spot structures downward so they bulge prominently into the vaginal cavity.
Enhancing a vaginal feature actually requires manipulating the urinary tract. It perfectly illustrates how complex and intertwined this entire region is.
Yeah.
You cannot just treat the pelvic floor like a collection of isolated cosmetic parts.
It is one dynamic, interconnected system, which proves why rigorous, objective clinical assessment must always precede cosmetic trends. You have to know exactly what you are injecting, what you are heating, and what you are structurally supporting.
So what does this all mean for you as a listener? We've gone from the GPS-like precision of the partograph saving lives in rural labor wards to the meticulous geometry of placing urethral slings, to debunking internet myths, and finally navigating the strange interconnected anatomy of cosmetic fillers.
It means that understanding the true mechanics of the pelvic floor is your best defense against misinformation and medical anxiety.
Knowing how this bridge is actually built empowers you. It allows you to walk into a clinic and ask the right questions. You don't have to be driven by subjective, anxiety-producing ideas of tightness. You can ask your doctor about objective support, muscle coordination, and true anatomical function. So as we wrap up this deep dive into the pelvic floor, where do you see the future of this field heading based on our sources?
The sources point toward a really fascinating shift in how we visualize the unseen. We discussed how transperineal ultrasound is now used to diagnose incontinence by measuring a 16-degree angle shift. But the sources also show ultrasound being adopted in aesthetic medicine.
Oh, like for facial fillers.
Exactly. For facial lip fillers, doctors use real-time imaging to map the labial artery to avoid injecting into a blood vessel and causing tissue necrosis. As this imaging technology becomes faster, cheaper, and universally available, it raises a provocative question for the future of women's health.
Judges.
Will pelvic medicine become entirely screen-based? Will the traditional hands-on physical pelvic exam, which relies entirely on a doctor's tactile feedback and has been the cornerstone of gynecology for centuries, eventually become obsolete? Will we stop feeling in the dark for the tension in the cables and rely purely on the digital readout?
Wow. From doctors navigating blindly by feeling the ischial spine to a future where everything might be maps on a screen in high definition. But whether it's measured by a doctor's hands in a rural clinic, a plastic POPQ ruler, or a real-time ultrasound, that suspension bridge is incredibly resilient once you know how it's actually built. Thank you so much for joining us as we unpack this incredible stack of sources. Stay curious, and we'll catch you on the next deep dive.